the things that we're going to be talking about tonight, we're talking about healthcare consent, we're talking about advanced care planning, of course, and values, beliefs, and wishes, and what that means in terms of advanced care planning. We're talking about substitute decision makers, what those are, power of attorney for personal care. We're going to be reviewing what DNRC forms are and how they can be useful. We're going to be looking at organ donation and at MAID. And hopefully by the end of the presentation today, you will have motivation to start the conversation now. We're also going to make available to you the resources that we talk about throughout this webinar. And at the very end of the webinar, we'll be reviewing how to find those. So healthcare consent. In Ontario, if something happens to us and we need medical treatment, healthcare providers have to get informed consent or refusal of consent in order to provide care. And in Ontario, though, consent for treatment can only come from a person, not a document. Living wills and advanced care directives are not recognized in Ontario and are therefore not legal. So really, wishes, things written down, they're not consent. If you are not capable of understanding your options and of giving the consent of the treatment that you choose, someone has to speak for you. All of that information can be very interesting when you think about the following stats. 76% of us, close to the end of our life, will not be capable of making decisions about our healthcare treatment. So these decisions then become the responsibility of someone else, and that person is called a substitute decision maker. And the process of helping your substitute decision maker understand what you might want in the future is called advanced care planning. So advanced care planning really is, it's a process. It's where you identify and reflect on your values, beliefs, and wishes, and what you want your future healthcare to look like. It's about identifying a substitute decision maker and then communicating what your wishes are to that substitute decision maker.
Okay, so probably the first question we need to ask as we begin the process of advanced care planning is, where do we even start? And really, it's a process of self-reflection. And in that self-reflection, we take a good look at our own values, our beliefs, and the wishes for what future care might look like for us. So when we talk about values, we're really looking at those things that bring meaning to an individual's life. This is a very individual process, and each of our values can differ greatly one from the other. So values could encompass personal qualities that are important to us, aspirations, relationships, the experience of certain emotions, or the experience of certain activities. All of these things need to be considered, and Dr. Hook has a story that demonstrates the importance of considering our values.
So thanks, Nichola. Yeah, I'm going to share some stories of things that happen to real patients. I've taken the names and changed them, and I've changed the circumstances so you can't recognize the person that I'm talking about, and to protect their privacy. So this is Lester. Lester was married with a son, and the son worked in Toronto. After retiring, Lester's favorite thing to do was work on cars. He bought old cars and restored them so they ended up looking like new. Then he sold them. He really enjoyed his work, and he was very proud of the finished results. But Lester had asthma. He developed chronic lung disease. He developed cancer and other medical problems over the years, resulting in many admissions to hospital. He required frequent blood transfusions. Eventually, he hardly had any time for working on his cars. Then his wife passed away. Before long after that, he was admitted to hospital with pneumonia and was found to have, in addition, heart failure, which made him short of breath. At that point, he said to me, Look, he said, my wife is gone. I'm on my own. I'm too sick and I'm in and out of hospital so often, I can't even work on my cars. The things that make my life worth living are gone. What would happen if I stopped my medication, doctor? He did stop all his medication, and shortly after, he passed away. So I'm sharing Lester's story because it's an example of how our values are about our reasons for living and how those values determine the decisions we make about our healthcare. Back to you, Nichola.
Thank you, Dr. Huck. So Lester's story is a really good example of how our values can certainly influence the decisions we make about our healthcare. And values, as mentioned, can involve personal qualities such as dignity, independence, and autonomy. They can also involve aspirations. We may aspire to maintain independence or to finish certain tasks. They can also involve relationships, friends and family, and in Lester's case, particularly his wife. Emotions are also to be considered. We may value experiencing the emotions of pride, joy, a sense of accomplishment, or a sense of legacy or comfort. And we also may very well value certain activities. So in Lester's case, he really valued restoring cars. That was something that was really meaningful and important in his life. So once we've had some opportunity to reflect on those very important values, which again differ for each and every one of us, it's important that we reflect on our beliefs. And our beliefs are those things that we accept as being true or real. They're often very firmly held convictions, and in some cases they might be religious beliefs, and there are principles that guide our lives. So some examples of beliefs that come up for people may be a belief that all life is sacred. Some people believe that there is meaning in suffering, it's not to be avoided. Other people might believe that we should actually minimize pain as much as possible, reduce suffering as much as possible. And a concrete example of a belief would be for people of the Jehovah's Witness faith tradition who would refuse blood products based on their religious convictions. So we've talked about values, we've talked about beliefs, and now we talk about our wishes. So we're becoming ever more precise in what we would hope for ourselves. Our wishes are based on our values and our belief systems. Oftentimes they're kind of if scenarios. So we might state, if this were to happen to me, this is what I would like to see happen, or this is what I do not wish to see happen. They can often be very broad instructions, for example, sharing that I never want to go into a nursing home. And they can also be speculations about the future. Again, if this were to happen to me, or in the event that this happened, or they may be based on real life known experiences. And another example of our wishes might be something like, in the event that I am in the hospital, I wish to make sure that there is a priest around to administer last rites. So they're the things that are really important to us based on beliefs and values. And I'll turn it over now to Dr. Hook, who has another example for us.
So this is the story of Hans and Martha. And these are two people who had ALS, or amyotrophic lateral sclerosis, otherwise known to us as Lou Gehrig's disease. And many of you may know that this is a neurological disorder that causes progressive muscle paralysis, ultimately causing trouble to swallow and eventually to breathe. So Hans was in his late 40s when he developed ALS. Martha was in her late 60s when she developed it. They both knew that sooner or later they're going to be unable to swallow and eventually unable to breathe. It was important for them to think about what they might choose to do when those complications happened. Hans was in hospital. When the question of needing a feeding tube came up, Hans said, "My 3 children are teenagers. I want to spend as much time as I can with them. is important for me to be part of their lives for as long as I can. So he chose to have a feeding tube inserted. Martha, on the other hand, by the time she was having trouble to swallow, she was in a nursing home. Her response was, I have no children and my husband is dead. I do not want anything done that would prolong my suffering. She did not consent to a feeding tube. So these stories illustrate the importance of understanding what might happen to us when we develop an illness, so we can think about what our wishes would be for future treatment for this illness.
All right, so with no advanced care plan, it can feel like this image. And I like how it says, my decision-making skills closely resemble that of a squirrel when crossing a road. So we all kind of can kind of understand what that would look like, right? Well, that's what it can feel like when there is no advanced care plan and you're in the middle of a healthcare crisis. So Dr. Hook, why don't you share that story again about the lady who had a stroke?
So yeah, this was a story that I was told by one of the doctors who worked at the intensive care unit in the hospital in Stratford. I didn't know her personally, but I want to share her story with you because it illustrated for me the importance of advanced care planning and the need to talk to our substitute decision makers about what's important about living. So I found out before that this lady, before her stroke, she was actually very active in the warmer weather. She loved to work in her garden and she'd go for long walks. She used to bicycle to get about town as much as she could. In the winter, she went cross-country skiing and for long walks. She loved the outdoors. Then her husband passed away. Shortly after that, she herself had a fairly massive stroke. It left her unable to speak or move. She had 2 children, a son and a daughter, who had families of their own and lived out of town. When this lady was admitted to hospital, she was unconscious and she was sent to the intensive care unit. Because she could not swallow, a decision had to be made about a feeding tube. Her son and her daughter both came to the hospital, but they couldn't agree about the treatment for their mom. The doctors had said that if she recovered, she would not likely be able to live independently. Her son thought she was not likely to get back to doing the things that she loved. So he wanted her to have palliative care without a feeding tube. Her daughter thought that she couldn't live with herself if she didn't ask for everything possible to be done. The problem here was that neither of them had ever talked to their mother about what made her life worth living or what she might choose. In the end, she did have a feeding tube, and weeks later she was able to swallow on her own and was eventually transferred to a nursing home. She never did recover. We'll never know what her wishes might have been if she'd been able to speak for herself. So this story shows us that without advanced care planning, we can end up with treatment that we might not otherwise choose to have. And that lack of planning can be very stressful for those left to make decisions for us, or sometimes result in conflict. Thanks, Hayley.
Thank you. Yeah, so now that we've talked about identifying, your values, wishes, and beliefs, what's next then in terms of the advanced care planning process? It's time to select a substitute decision maker. And we have a short video on this.
Imagine you're in the hospital, too ill or hurt to speak for yourself. Do you know who would make your healthcare decisions for you? There seems to be a bit of confusion around who can make healthcare decisions for us when we are not capable of making them for ourselves. We hope this video can help you understand how healthcare decisions are made in Ontario and by whom. To put it into context, in Ontario, before giving you any treatment, healthcare providers must get your permission. This is called informed consent. Healthcare providers must give you all of the information needed so you can make an informed decision about your treatment or care. It is important to note that healthcare providers do not make the decisions for us. The only exception of when informed consent is not needed is in an emergency. So who do healthcare providers get consent from? Ideally, it comes from you as the patient. After all, it is about your healthcare. However, there may be a time when you are not mentally capable of making your own decisions. In this case, the healthcare provider will turn to your substitute decision maker, or for short, your SDM. This is the person or people who are legally authorized to make your healthcare decisions for you if you are not mentally capable of making them yourself. Every person in Ontario has an SDM because the law has given us all one. There is an automatic ranking list called the Hierarchy of Substitute Decision Makers and is outlined in the Healthcare Consent Act. So who is on this list? Before we go through it, there are a couple of things to note. It is in ranking order, which means healthcare providers by law must speak with your highest ranking SDM. Also, if there are multiple people on any of the levels, they are all equally ranking SDMs and must agree on the decisions together, or must decide amongst themselves which of them will act as your SDM. Now, let's look at the hierarchy. As you can see, it is grouped into 3 categories: legally appointed SDMs, automatic family member SDMs, and SDM of last resort. Starting at the top of this list, the highest ranking SDM is a guardian of the person. This is someone who is appointed by the court to be your SDM. This is a relatively rare circumstance. The most common legally appointed SDM is the attorney named in a power of attorney for personal care. This is the person or people you have chosen to be your SDM in your power of attorney for personal care document. Attorney in this case does not mean lawyer. Attorney means the person you have chosen to be your SDM. For more information about power of attorney, visit the Ministry of the Attorney General's website for Ontario-specific resources, or visit your lawyer. The third type of legally appointed SDM is a representative appointed by the Ontario Consent and Capacity Board. This is another application, but this time to a tribunal. For more details on becoming a representative, please visit the CCB's website. If the legal steps noted above have not been taken, you still have an SDM for healthcare. The following family members are your automatic SDMs. The highest ranking family member SDM is your spouse or partner. Spouse or partner can be same-sex or opposite sex and means you are married to each other or are in a common law relationship, meaning you must be living together for at least 1 year, are the parents of a child together, or have a cohabitation agreement. 2 people can be deemed partners if they have lived together for at least 1 year and have a close personal relationship that is of primary importance in both people's lives. The next level is parents or children. This level includes all adult children and your parents. If children are in the care of Children's Aid Society, it is the Children's Aid Society that is the SDM for the children. Level 6 is if a parent only has visiting access to their children, he or she falls at this level. Level 7 is all your brothers and sisters. Level 8 is any other relative, and this is by blood, marriage, or adoption. If no person in your life meets the requirement to be an SDM, then the Office of the Public Guardian and Trustee, a government-appointed representative, is the SDM of last resort. The Public Guardian and Trustee will also act as your SDM if there is conflict among equally ranking SDMs who all want to act but cannot agree on the decisions about your treatment. The public guardian and trustee does not choose between the disagreeing SDMs, but is actually required to make your healthcare decisions for you. In order for someone to act as an SDM, they must be highest ranking on the list and meet all of the following criteria. They themselves must be capable. They must be at least 16 years old. There cannot be a court order or separation agreement prohibiting access to the incapable person. They must be available. Healthcare providers must be able to get a hold of them in the time frame needed. And finally, they must be willing to assume the responsibility of being an SDM. Nobody can be forced to act as a substitute decision maker. If your highest ranking SDM does not meet the requirements, the healthcare provider will then turn to the next person on the list. So now what? We encourage you to think about who you want to make your healthcare decisions in case one day you are not able to make your own. Is this person the highest ranking on the list? If yes, you do not have any legal paperwork to fill out. They will be your SDM automatically. If they are not, you may want to consider completing a power of attorney for personal care. Remember, while you don't need to have a lawyer prepare your power of attorney, they will be able to answer any questions you have and provide you with advice about your specific situation, so it may be a good idea to speak with a lawyer. So, when should you decide who will make your healthcare decisions for you if you can't make them for yourself? Now! It's always too soon until it's too late. For more information about healthcare consent, advanced care planning, and substitute decision making, please visit the following websites.
There we go. Just bear with me. There we go. Sorry about that, folks. Thanks for your patience. All right, so that hierarchy, here it is again. And this hierarchy of substitute decision makers is going to be an image that we're going to be sharing at the end of the slide as well. So I'm not going to go through them again. Just know that we're going to show you this image again so you can, so no need to scribble down too fast right now. It'll come back, okay? So facts about a substitute decision maker. Nichola, take it away.
Thank you, Hayley. So what's really important to know here is that a substitute decision maker is a person who makes healthcare decisions for you when you are not capable of doing that. And every single one of us in the province of Ontario has an automatic substitute decision maker, as is outlined on that hierarchy that was shown in the video and that Hayley mentioned. What's really important for us is to take a good look at that hierarchy and see who is our automatic substitute decision maker. When we look at that and we see who it is who would be making healthcare decisions for us, we have to ask ourselves, is this the person that I want to be making healthcare decisions for me if I'm not able to do so? If your highest ranking substitute decision maker on the hierarchy is in fact the person you want to make your healthcare decisions for you, then you don't have to do anything. If, however, this is not the person who you want or trust to be making healthcare decisions for you, then you have to consider filling out what we call a power of attorney for personal care form. So the power of attorney for personal care form, or the POA, as you may have heard it referenced before, is a form that's filled out, again, if the substitute decision maker in the hierarchy is not the person that you want to make decisions for you. In order to get this form and to fill it out, we have several options. You can go online. You could call Service Ontario in one of their publications, or you could consult with a lawyer. A lawyer is not required to fill out a power of attorney form, but they can often be very helpful in answering any questions that you might have and supporting you through that process. And remember, it's always too early, or it seems too early to do this stuff until it is too late. So we now have a video about choosing a substitute decision maker. And Hayley will get that queued up for us. Thank you, Hayley.
You're welcome. One moment here. All right.
Great. Thank you, Hayley. So there are some requirements in order to be a substitute decision maker in Ontario. First of all, the person has to be willing to be your substitute decision maker. As it mentioned in the video, you can't ever be forced to be someone's substitute decision maker. The SDM also has to be mentally capable of making healthcare decisions for you. They also have to be available, and that means either in person or by telephone or some other reasonable means when a decision needs to be made. So they need to be reachable. They must also not be prohibited by a court order from acting as your substitute decision maker, and they have to be at least 16 years of age.
So let's recap that. Thanks, Nichola. So questions to ask your substitute decision maker. Do I trust this person? Can they make decisions under stress? Are they willing to take on this role? Are they able to take on this role? And then it's time to talk. So if you are thinking, oh, I might be a substitute decision maker, we've got a video for that as well. So here's another video and bear with me for just a moment. All right. So, advanced care planning. It's about thinking about your values, wishes, and beliefs, identifying that substitute decision maker. If your SDM is not highest ranked on that automatic list, which we'll be showing you shortly, make them your POA by filling out a POA form. Now, the POA forms can be given, excuse me, to the SDM, and excuse me, or they need to be kept in a safe place where the POA or the substitute decision maker can access them. And talk about your values, your beliefs, and your wishes with your substitute decision maker, and keep that conversation going. Now, remember, if the automatic substitute decision maker is not the person you want, again, I know we're being so repetitive, but we just want to make sure people understand you need to identify that power of attorney for personal care. So you have to fill out that POA form. And again, it's a legal document. It doesn't require a lawyer, but a lawyer can be helpful. And the paperwork must be readily accessible. So either make sure that the POA has the paperwork or knows where to find it. Here are some websites where you can actually get the POA forms. And here's a little bit of what it looks like. Yeah, and these resources, we're going to be showing you these resources at the very end of this presentation, so you'll have a lot more time to write them down. I really like that Service Ontario, you can literally call them and they will mail you one. So that's a great feature as well. All right.
Just before we move along to the Do Not Resuscitate confirmation form, or the DNRC, I believe Dr. Hook had an example about a man named Ron who really demonstrates for us the importance of the advanced care planning process.
Yeah.
Am I correct in thinking that? Yes.
That's right. Thanks, Nichola. Yes, Ron, this is one of my favorite stories. So something that was important to Ron was being useful to others. It was important for him to be able to help his family and the wider community. He made a sandbox for one grandchild, a wagon for another, and metal swings for two more. He helped his children with their home renovations. He made furniture for his grandchildren when they moved out to university. After he retired, he would salvage discarded bicycles or furniture and take them home to repair. Then he would take them to the church sale. He and his wife were always big contributors to their annual church sale. He really enjoyed helping his neighbors. Eventually, Ron's wife died, and he developed a problem with his bone marrow that made him anemic. Blood transfusions were offered to help buy him more time. He became weaker, and he had a series of falls. And one day, when all his children were home, he told them that he did not want blood transfusions or any other medical treatment. He felt he was no longer able to be useful to anyone and no longer able to be helpful to his children, and this was what was important to him. He got a DNRC form from his doctor. As he deteriorated, his children all helped to look after him at home until he passed away. This was how he wanted it, and he had made this clear to all his children. Because of that, his children, though very sad, ultimately felt good about how he had died. Back to you, Nichola.
Thank you. So the DNRC form is actually the only form of advanced care directive that is legal in Ontario. And it came into play because emergency responders, if called to your home, are mandated to provide CPR unless there is a completed DNRC form in the home, typically on the person's fridge. What this form specifies is that there is to be no CPR performed on the person. This is a form that needs to be obtained from a family physician, and the forms are numbered. So each person who requests one would only have one copy. It must be signed by a medical professional. And as I mentioned, it has to be posted so that the first responders can see it, and they typically would go to the refrigerator to look for it. If this is something that you think might be something that you would want to consider for yourself, a conversation with your family physician could set those wheels in motion. And this is just a copy of what the DNRC form looks like. So often when we do these presentations, people have questions about sort of other medical issues, and organ donation is one of those. Organ donation in Ontario is managed by the Trillium Gift of Life Network. In order to decide to become an organ donor, you need to be at least 16 years old and provide for the Trillium Gift of Life Network your date of birth and your health card with version code. It is very important to register because connecting with the Trillium Gift of Life Network and registering there is the only secure and guaranteed way to make your decision known. It ensures that this decision is recorded, even if you have already signed a donor card. So the Trillium Gift of Life Network would use your record to confirm your consent. They do reconfirm consent with family. And in almost all cases, if the family knows that the person has made this decision and has registered with the network, they almost always reconfirm consent and honor the person's wishes. So if this is something that you might consider registering for, you can do that online at the Gift of Life website listed there. You can go in person to your local Service Ontario Centre, or you could print and mail a Gift of Life consent form. And as was mentioned in the beginning of this presentation, all of these resources can be made available to you at the end. So please don't panic and feel that you have to write all of this down right now. Another medical situation or option, I guess, that is often asked about in these presentations is about MAID or medical assistance in dying and who might be eligible for this. So there are a number of conditions that must be met in order to be eligible. The first is that you must be eligible for publicly funded healthcare in the country of Canada, and you must be 18 years of age or older. You must be capable of making your own healthcare decisions and have a grievous and irremediable medical condition. You must have serious incurable illness, disease, or disability, and be in an advanced state of decline in capability. You must also be enduring physical or psychological suffering caused by the condition and the state of decline that has become intolerable. And natural death must have become reasonably foreseeable. So just as far as the medical assistance in dying goes, if that is something that you would like to learn a little bit more about or discuss further, you can certainly have that conversation with your family physician.
Great, thanks, Nichola. So, questions to consider regarding advanced care planning. Who is going to speak for you if you are unable? Who are you thinking? Who is your automatic substitute decision maker right now? And we're going to show you that image. Does your automatic substitute decision maker know that they're your substitute decision maker? Is your SDM highest ranked on the automatic list of SDMs? If your automatic SDM is not who you want them to be, how will you get your POA forms? Things to think about as well, where you're going to keep them. And then really, we want people to really understand it's so important to really reflect on your values, your wishes, and your beliefs. And does your SDM or your POA, does your substitute decision maker or your power of attorney for personal care know them? And again, I know we've said this before, it really does seem always too early and too soon to talk about this before it's too late. So please start the conversation now. So here is that automatic hierarchy image, and we're going to keep this on the screen. Here are the resources that we've also mentioned as well. And again, we will be having this presentation, this webinar, and the PowerPoint available on our Star Family Health Team website. But now I'm so proud of us. We are just a minute after our 45 minutes that we gave ourselves. So we would love to answer any questions that you have. So Teresa, I'm gonna just pass it over to you, and I'll let you, kind of go through any questions that have come either in through the chat box. And if they haven't, people are welcome to use that. And well, if we don't have anything right now, we've got a couple of questions that are prepared and we'll go from there. So Teresa, take it away. And Teresa, if you wanted to just unmute yourself, there you go.
Here. So there isn't any questions in the chat box at this time. So we may want to go to the next slide that presents some challenging questions that we thought of as a group that are often common questions that come up. So first question is, in preparation of my will, the lawyer put a clause in the will indicating if I have an illness for which there is no hope of recovery, that I am not to be resuscitated if my heart stops. How does this fit with advanced care planning? And Dr. Hook, you're going to provide the answer for that?
Thanks, Teresa. Yeah, well, as we heard in the slides, when something happens to us, if we develop a new illness, we have to give consent for treatment, and that consent comes not from a document, it comes from a person, either the person who is sick or their substitute decision maker. So if you have something in your will that says that you don't want resuscitation under certain circumstances, that really amounts to a wish, which could be helpful in guiding your substitute decision maker, but it's not consent. We still need, as healthcare providers, we still need to get consent from a person, a living person, not a document.
Okay. Thank you for that answer, Dr. Hook. And I did receive a question in the chat box, and this question is from Phyllis. I have a DNR form for my mother, but there is no serial number on it. Will this cause problems in the future? Dr. Hook, would you like to answer that question?
So I wonder what that DNR form is and who wrote it. If it is not one of the ministry authorized DNR forms, yes, thank you, one of those with a serial number in red in the upper right-hand corner, it may not be respected by the first responders if they come to the home. So if you don't have one of these forms, I'm not sure if what you have would be respected. I would suggest that you go to your family doctor and get one of these authorized forms and be sure that it's on display somewhere in the home, so first responders will see it.
Okay. Thank you, Dr. Hook, for that answer. And as a registered nurse, I'm aware that these as numbered forms, the paramedics who enter the home have to see that the form is authorized, as Dr. Hook had mentioned. It has to have a serial number at the top. And there's a likelihood that the paramedics will not be able to respect the form that you have there. So you do need to have a numbered form. So another question is from Linda, and her question is, informed consent to the doctor. How do we do that?
Okay, so that happens with a new diagnosis, and it's part of a discussion. When something happens or you have a new diagnosis, the physician will normally explain what that is, what the complications are, what the treatments are, what the benefits are of the treatment, what the risks are with the treatment. And then a decision has to be made. And technically, in order to make that decision, the person has to be capable of understanding the implications of the decision that they're making. They have to be able to understand the nature of the disease and the complications that are being discussed by the physician. And they have to be able to understand the consequences of the choices that they make. So it's a two-part aspect. You have to have a physician provide information, and you have to have a capable patient who can understand it and give consent. And if they can't, then it will be up to the substitute decision maker.
Okay, thank you, Dr. Hook. Another question came in. Who would be the attorney for personal care that is listed in the top of the automatic list?
So that's the attorney for that's the person who is named in the power of attorney for personal care, which you write down. Okay, so in order for you to have an attorney for personal care, you have to complete an attorney for personal care document assigning that responsibility to a person. So this is a written document. This is not something that's done verbally. And this is something that a person can do themselves. And there are the resources to do that.
Okay. Thanks, Dr. Hook. Now, there isn't any more questions in the chat box. And certainly as participants, you'll keep adding your questions. We'll just go to the list of questions that we've provided. And we're on, I think, question 3. Oh, question 2. So this question is, my mom is in a nursing home. On admission, she signed a form that indicated the level of care she would receive if she develops a serious or life-threatening illness. What happens with the decision she made when she signed that form if she gets sick? Dr. Hook, would you be able to answer that question?
So this is very similar to the issue that came up about somebody having a clause in their will. Because once again, this form documents the wishes of the patient, but it's not consent. So this form, even though it's signed by the patient or their substitute decision maker, might indicate a preference. But if something happens, then that's a discussion between the healthcare providers and your mom in the nursing home, or you if you're her substitute decision maker. And at that point, you make a decision about how she's to be treated.
Okay, thanks, Dr. Hook. There isn't any questions in the chat box. So Hayley, if you can go to the next question, please. Oh, okay. Question number 3. My sister lives in Alberta and she has signed a living will which has details about what she might want if she has a terminal illness. Can I prepare a living will? Dr. Hook, would you answer that question?
And the answer here, if you live in Ontario, the answer is no. In Ontario, living wills, advance directives have no legal standing. And in Ontario, we get consent from a person, either the person who is ill or their substitute decision maker, and we do not get consent from a document.
Okay, thanks, Dr. Hook. Next question. Number 5, I have 4 children. What if they can't get along when it comes to making decisions for me? Who would the doctors listen to? Dr. Hook, would you answer that question?
Yeah, this is a really great question. And I've been in situations where this actually was a problem. And what the law says is that everyone who is at the same level on the hierarchy have an equal voice in making decisions as a substitute decision maker. And the healthcare providers will do what they decide, but they have to agree. And here's where it gets tricky, because if they can't agree, then the healthcare provider must, and that's in uppercase letters, must refer the decision to the public guardian and trustee. So do I really want the public guardian and trustee making decisions for me instead of my children? Probably not. I don't want somebody who's sitting in an office in Toronto or London or Hamilton making decisions about my healthcare. So there are a few ways out of this situation. The children can decide among themselves who is to make the decisions. Some of them, if they're having trouble reconciling their views, can withdraw as decision makers. Or they can elect one of them to act as the SDM for that person. So I think one of the things about this is that really highlights the importance of having those conversations with our children, so they don't have to argue with one another about what I want. Yeah.
Thanks, Dr. Hook. Brenda has provided, has put a question into the chat box. At what point and how is a person determined to be incapable? Dr. Hook, would you be able to answer that question?
Yeah, and that's a really good question.
Mm-hmm.
And the law assumes that we are all capable unless there is evidence to the contrary. And being capable depends on the question that's being asked. So to be capable, I must be able to understand the question and to understand the implications of the choices that I make. And I might not be capable of managing my finances, but I might be capable of deciding where I want to live. I might not be capable of understanding all the details of treatment options that my healthcare provider might be suggesting, in which case I would turn to my substitute decision maker. But I still might be capable of deciding who my substitute decision maker will be. So capacity depends upon the question that's being asked, and it requires the person who is answering to understand the questions and to be able to understand the implications of the decisions that have to be made.
Thanks, Dr. Hook. There's a number of really good resources that should be able to support you and help you when you're providing or you're doing your advanced care planning. The main source of information for this presentation was the Speak Up Ontario website. So speakup.ca, and there's a comprehensive list of excellent resources that provide us a step-by-step guide. And it actually helps you in that kind of planning and decision making, helping you to figure out what your beliefs, your values, your wishes are. And these resources, as Hayley has mentioned, it's been mentioned a couple of times, that these resources will be available as a slide deck on our website. And this video will also be recorded and will be available on our website.